Sorry, just going to share my screen. Okay, I've just started the recording now. I'm just trying to share the presentation just quickly while I'm just waiting for that to load. Just the usual, housekeeping. Please keep your cameras off at all time. Please keep yourself on mute unless you'd like to ask a question, and raise your hand and put it into the chat. As Amanda said earlier, we will be sharing the presentation and recording with you after the event. So, so welcome everybody. I'm just waiting for the presentation to load. It was working fine earlier. Can everybody see that? Yep. See that, Amanda?
Yes, we can. Yes, we
Okay.
can. Thank you.
Right, I'll hand over to you now. Thank you.
So good morning, everybody, and welcome to today's session, Norovirus Training for Local Authority Response Teams. I'm going to ask my colleagues, Susan Hughes and Emma Woodcock, if they're able just to put their cameras on, and anybody else who's been part of today's session, just so I can do some introductions. So my name is Amanda Henry. I'm one of the Senior Health Protection Practitioners at the UK HSA. I'm joined today by my colleagues. Emma, would you like to introduce yourself, please? Thank you.
Hi, everybody. Some of you might have heard me or seen me on IMT. So I'm Emma Woodcock, one of the health protection practitioners, health protection nurse based at UK HSA, formerly PHE. Welcome, everybody. Hopefully you'll enjoy the session.
Well, thank you. And Sue, would you like to introduce yourself, please? Thank you.
Yeah, good morning, everybody. My name is Susan Hughes. You can call me Sue or anything that comes to mind. Yeah, we're all, well, and Amanda, Emma and myself are all clinical practitioners, and we've all worked in local authority. So we have an empathy with what you're going through at the moment. So we're aiming to do a presentation for you that will help you to try to understand the basics of norovirus. I apologise in advance if these slides are not designed to talk about the experts amongst us, because I guess there are people here from an expert background, and there are also people from a background of perhaps not having as much experience with norovirus. So we've tried to cover every eventuality. Slides are guides, and that's what I always say. There's always more to talk about, so please interact as we go if you need to. I always talk too much as well, sorry.
Thank you. So I'm going to hand over now to Sue, and a big thank you to Raj Atwell, who has been coordinating and put together the platform for us to have the training today, and we'll also be sharing the slides and the recording and some also additional resources, norovirus toolkits to support colleagues in the local authority managing norovirus outbreaks. So over to you, Sue. Emma and I will turn our cameras off. Raj, thank you for driving the slides.
Yeah, thank you. And I may need to turn my camera off partway through, because I do tend to lose reception if I leave my camera on, and you don't always want to see my pretty face anyway, do you really? So, okay, so we'll start off by saying, could I have the first slide, please, Raj?
Sorry, it's just froze on me.
That's okay. As they do. I think I'll turn my camera off because sometimes that happens when my camera's on as well. So sorry, I'm going to disappear for a minute.
Looking again. Right, sorry about that.
No, that's okay. Don't worry. We all have these problems, don't we? So just while we're waiting for Raj to put the slides up then, you're all from local authority backgrounds, oh thanks Raj, and presumably you've all been working on the COVID cells, and I guess now we're coming into norovirus season and the winter pressures, you're going to be expected to take some of these calls. So I've done a few slides that just tell you a little bit of background about, what, how, why, what and who is norovirus, and then we're going to do some sort of infection control, which are the main points that you need to cover with care homes and schools, which are going to be the predominant people who are going to be calling you. Amanda, Emma and I are going to share the slides out so that you don't get bored with my voice. Okay, so we've got that first slide there. What is norovirus? So it's a microscopic enteric virus which affects your gastrointestinal tract. It's a small round structure. It's a non-enveloped single-stranded RNA virus. It's called norovirus because it came from Norwalk virus, which was named after gastroenteritis outbreak in Norwalk in Ohio in 1968. Sometimes it's called stomach flu or a stomach bug, but this virus is not related in any way to flu caused by influenza virus or indeed to COVID. It is very contagious. It needs a host to survive and replicate. That means that any sort of virus can live and survive and replicate, so it can duplicate inside somebody's body or a live person. But what it can't do is replicate and survive for long periods of time outside a human body. However, we know that it can live for 14 days on environmental surfaces and in the environment. And we'll talk a little bit about that later. It can also survive temperatures of 145 degrees Fahrenheit. Now, every time I do anything to do with norovirus, and I've lived with it for about 12 years now, being an infection control nurse, I learn something new about norovirus every time I read about it. And that's the one that I learned this time. So it can survive at temperatures of 145 degrees Fahrenheit, which means that's a quite high temperature, and it's higher than body temperature as well. So next slide, please. Sorry, my voice is going. Sip of water. So who can get norovirus then? Anyone can get norovirus. Worldwide, there are approximately 1 in 5 cases of gastroenteritis which are caused by norovirus. 685 million cases are known annually worldwide. This we're talking about. 200 million children under 5 can get norovirus, and in the poorer countries, this has been known to lead to up to 50,000 deaths in children in those developing countries. New strains cause an increase in outbreaks. However, since 2012, a strain called the G11.4, which is a genogroup 11 genotype 4, has been the dominant strain causing outbreaks. You don't need to remember all that. This is just a bit of background information. It's not something that you're going to need to talk to your care homes or schools about, but that's just in case there are people on here who might get bored with the normal foundations of infection control, etc. There is also ongoing work to develop a vaccine, and I've put the link in there. And again, I learned that by reading a little bit more about norovirus this year. Okay, next slide, please, Raj. So why is norovirus so virulent? Antibiotics don't work with norovirus. They work with bacterial infections, and this is a viral infection. Very contagious people shed billions of norovirus particles. Okay, and you only need as little as 18 particles to infect someone. Now, I have read information that says you only need as little as 10 virus particles to infect someone, but as this said 18, I thought we'd use that one. But just to compare that, you need about 10,000 virus particles to catch flu, and you know how easy it is to catch flu. So norovirus is much, much easier and much more contagious to catch. You can also have asymptomatic carriers. So children are often carriers of norovirus without any symptoms. And we've seen this, haven't we, in COVID, both in children and adults. If you get someone who's asymptomatic, it's like that invisible virus, isn't it? You don't know what you're dealing with, which means that we have to employ standard precautions wherever we go because we don't know who might be carrying that virus. We also know that the strain can change frequently. each season, it's thought, so that people can get the bug more than once. Because what we don't think we do is build up a solid immunity, but we do know that some immunity exists, but we don't know how long it lasts. It's thought to be about 6 months, or when that virus is seasonal. Next slide, please, Raj. Yeah. So when do you get norovirus? Outbreaks usually occur in the cooler seasons. So in the northern hemisphere, it's usually November to April. In the southern hemisphere, it's May to September. And in countries near the equator, it's less seasonal. It can happen anytime. Okay, next slide, please. Raj, yeah. And how is norovirus transmitted then? How is it spread? And this is the nitty-gritty, really. So this is one example. So if you're providing care or changing, this is CDC, so it's a little bit Americanized, I'm sorry. So if you're changing diapers or nappies, and then you don't wash your hands and touch your mouth, or you could shake hands with someone, or you can touch a contaminated surface and then touch your mouth, you can become ill with norovirus. This is one way that it's transmitted. It is via the fecal or oral route. So we'll talk about that in a little bit. I don't want to jump slides. So next slide, please, Raj. And this is a second slide about transmission. There's a lovely diagram there, and I'm not sure whether, Raj, you might be able to double click on that diagram and make it a little bit bigger so people can see. It's one that I found, and I just thought it was quite a nice one to share. Okay. So on the on the left, you can see it's called the F diagram, and on the left you can see a little boy there, or a depiction of a little boy having a poo. Let's talk like that. So spreading feces, that can be picked up then by fingers, flies. I can't read the next one, but I can't remember what it was now. Fields, that's the one, or fluids, that's it. I found it last night and I thought it was really good. Fingers, flies, fields, or fluid. It can then be picked up in either soil, water, transmitted by these insects or by hands into foodstuffs, which means that you ingest it. And then obviously you can get norovirus that way. And when we pass stool sample at the end of the day, then that cycle starts all over again. If you can see the blue lines there, sorry, could you just leave it up for a tad longer, please, Raj? The blue lines there, yeah, are showing us how we can prevent that transmission. So the first blue line is toilet hygiene. So making sure that, you know, when you go to the toilet or when people go to the toilet, then they wipe themselves correctly. We've got good sanitation in place, and then commodes are cleaned if we're looking at care homes. Then that second blue line there is keeping safe water. That's a little small line, but that just is active when we've actually got transmission via water. The third blue line there is all about hygiene and keeping things clean and decontamination in the environment. So that would prevent that transmission happening there. And then the last blue line is hand washing. So I just thought that was a good picture image. Thanks, Raj. We can go back to the normal slide now. So then close contact with someone who has norovirus, and some people, particularly children, as we said, can be asymptomatic carriers. Eating food which has been handled by someone with norovirus. So it's important if you're dealing with a care home, and I suppose I'm zooming in a little bit on care homes because these are the people that you'll be dealing with most of all, or indeed schools. If you've got anybody who's working in the kitchen, who's had or been in contact with somebody with norovirus, you've got a risk of transmission there, because obviously if they're preparing the food for everyone, then that's going to be transmitted through the food into people's mouths. And then the last one there is airborne. So droplets from vomiting can become airborne, and these can enter your mouth if uncovered. We've found that projectile vomiting can stretch for up to 3 meters. So I know we've been used to 2 meters with COVID, but if somebody projectile vomits, it could land on surfaces up to 3 meters away. Next slide, please, Raj. And then where does norovirus happen? So mainly where people are sharing these communal facilities and they have close contact. So care homes, top of the list there. Hospitals, which we know where there are very often outbreaks of norovirus. Schools, prisons, and cruise ships. Cruise ships particularly because they're enclosed and there literally is no escape from them if you're in the middle of an ocean somewhere. And there's a newspaper headline from pre-COVID there, 30 inmates struck down by norovirus in the West Midlands prison. And we're now seeing more headlines of norovirus outbreaks in high-risk settings, for example, care homes during nationally while COVID's circulating as well. Okay, next slide, please, Raj. So what are the symptoms of norovirus? So the common symptoms are vomiting, and that does tend to be projectile, diarrhea, and that's watery diarrhea as well, and frequent, stomach cramps and nausea. Possible symptoms, you can also get high temperature, headache, body aches, but not always. You don't always get these secondary symptoms. I'll also say that with the common symptoms, I have seen that you can have vomiting without diarrhea and then diarrhea without vomiting in a number of people within the setting. So always bear that in mind. Some people don't have the stomach cramps and some people don't have nausea. So I think, you know, you don't have to get all those 4 symptoms to say that you've got norovirus, or indeed not a lot of people have to get all of them. It causes inflammation of the stomach or intestines, which is acute gastroenteritis. That's how you'll hear it termed, and consequently causes dehydration. So the important thing is to keep people hydrated when they've got norovirus symptoms. The incubation period is approximately 12 to 48 hours. Okay, next slide, please. What's the treatment for norovirus? There is no therapeutic treatment. It is a self-limiting disease. The main thing we need to do, as I said, was rehydrate people. Make sure that they're drinking plenty of fluids. If you have got children who are not drinking well, you can contact the GP and they will give you some rehydration sachets. That's obviously up to the parent to do. We can advise that if that happens. Antibiotics, as I said before, are not effective against norovirus. That's important to remember, and it won't cure it. Okay, next slide, please, Raj. Roles and responsibilities. Just wanted to talk a bit about this then, because you've got a little bit of background about norovirus and what it is and where it comes from now. But when you're speaking to organisations, you need to really explore what their roles and responsibilities are. Now, because we're not involved in commissioning or indeed actually carrying out treatment or prescribing. We can only advise, and that's similar for yourselves as well. So you need to ask them what in their organisation, what are the policies and procedures there. Have they got an outbreak policy? Is their exclusion policy and sick leave policy, are they up to date? And do they actually say that people can't come back into work if they're staying at home for 48 hours after their last symptom, which is really important. So when we're talking about schools, if we're talking about children who are showing diarrheal symptoms, they can be sent home. That's the easy fix, really, because you don't spread it around the organisation that way. They need to stay at home for at least 48 hours after their last symptom, whether that's diarrhea or vomiting, okay, because they're infectious during that period of time. If you're in a care home situation, that is more difficult because you can't send care home residents home because they're already home. What you can do, though, is send staff home. We have found in the past that it is sometimes difficult and a fine line to tread between care homes sending staff home and having staff in the care home, enough staff to provide safe levels of care. And this is where you find those blurred lines. So care homes need to have a contingency plan. What do they do if, you know, there's a lot of their staff off and they're finding that they can't provide that safe care? Or in a school, what do you do if all the staff are affected and you know, there aren't enough staffing to provide lessons, face-to-face lessons with children? And all the organisations need to have that contingency plan in place. It's not your responsibility to tell them what to do, and indeed we can't close schools. I think you're all aware of that. That needs to be a decision that teachers and governors make between themselves, and they need to be operational at safe levels. Have they got an infection prevention and control policy in place? So, you know, is it in place? Is it a piece of paper in a folder? Or are they actually doing it on a regular basis? Because normal standard infection prevention and control is there all the time. It's not just when you get an outbreak. If it's there all the time, people are familiar with it, they know what to do about infection prevention and control, and it should be standard practice. You know, you don't just dust off the policy book when you get an outbreak. So make sure it's visible, it's easy to access, and people know where to find it. So are people up to date with the infection control training? That's important as far as cleaning staff are concerned as well, food and hygiene training. We need to make sure that, well, you need to advise that all their staff are up to date with all this training, because if they're not going to be able to just throw themselves into, you know, training mode, are they? As soon as you've got an outbreak, you've got enough to do when there's an outbreak without thinking about back to basics. The basics need to be there already. That quality control also needs to be in place. So do they do hand hygiene audits, particularly in care homes I'm speaking about here? That should be a regular process. Are they making sure all the staff are, you know, bare below the elbows, and, you know, do they know how to employ those correct hand hygiene techniques? Cleanliness audits, Emma's going to speak about decontamination shortly, but you know, are they doing audits to check that the areas are clean? Who cleans the equipment? Whose responsibility is it? How do you know equipment's been cleaned? You know, have they got a labelling technique? Do you know that, you know, if you've used that commode for somebody, what's their process for saying who cleans that commode? What's the process for saying who cleans the toilet while the carer is walking, you know, Annie back to her bedroom when she's just had norovirus in a toilet? You've got to look after the residents first, haven't you? But then, you know, what's the trigger to say don't nobody else use that bathroom until, you know, it's been cleaned? How do they know that? And these are the questions to sort of ask these homes. Then they need to consider how they're going to communicate this outbreak to stakeholders. And when I say stakeholders, again, I'm sort of homing in on care homes a little bit, but, you know, who tells the local trust? That's important in case anyone is admitted into the trust, because what you don't want to do is take norovirus with you into the trust with your resident, because then you'll have an outbreak in the local hospital, won't you? To the CCG, to the CQC, to the district nurse teams, to people who are going to be entering the homes or need to enter the homes for reasons other than visiting. Because what you would do is close the homes to visitors, admissions, transfers. But what you can't do is close the home to people who need that regular care. So if you've got a diabetic in the home who needs regular insulin, for instance, and the district nurse comes in to do it because it's a residential home, it's who tells the district nurse that there's norovirus in the home, because they might need to plan their day according to that. So, you know, if it's not as important as insulin that they need first thing in the morning, if it's a dressing, I could leave that till last on the list so they don't risk taking norovirus around to other homes. So all these things need to already be in place with the care homes, but it's always worth revisiting those type of things. And then staff management. I talked about this a little bit earlier. So have they got correct levels when people are off sick? Where are they going to place the staff? If you're cohorting people, have you got somewhere that you can actually put a group of staff and know that they're dealing with that cohort of perhaps non-symptomatic people against, you know, with people who are dealing with the people who are symptomatic, so that you don't cross over with that staff and mix them up. And then is all the health and safety in place, and have they got all the right PPE in place? So what your role, I guess, is asking who is responsible for doing all those things in that organisation. Sorry, that was a long slide, but next one, please, Raj. Oh, right. Okay. So I'm going to hand over to Amanda now, who's going to talk through a little bit about if an outbreak is suspected. You've fed up with my voice by now, I'm sure, anyway. So over to you, Amanda.
Hello. So when you suspect an outbreak, we traditionally think of the definition as 2 or more in a care home residents who have an unexpected, unexplained diarrhea and or vomiting, and the home may be experiencing an outbreak. One of the things I want to stress that we know in our care homes, there's lots of reasons why our residents are vulnerable. Age, comorbidity, they may be on long-term antibiotics, which make them more susceptible to having diarrhea, and they may also have infective diarrhea, norovirus as well. I think it's really important that we appreciate into our local authorities, different sectors such as education will call us. So if a school, call your COVID response team, reporting a suspected or probable norovirus outbreak, it's really important as local authorities will be asking you to initially manage that outbreak and give advice, health protection advice, and trying to contain that outbreak. If then the local authority find it challenging, or there are more concerns, for example, food source or challenges in terms of business continuity and not enough staff to keep the school open, as Sue has alluded to, it's a school decision with the governors for closing, but it may be then appropriate time for local authorities to be calling the UKHSA for further advice and support in managing that outbreak. So for care homes, by all means, care homes can call directly through to the UKHSA. They can also, and should do, let the local authority know their high risk groups. But for schools, please do ask your schools for your health improvement officers or your officers who work with the schools in your local authority areas. Ask schools to notify local authorities first, and then we would be asking the local authority to escalate up to the UKHSA if required and if appropriate. It's really important for care homes that when there's a suspected outbreak, they let the GPs know who look after the residents. So some care homes have one GP practice that looks after all the residents, and some have several GPs. It's important to let the GPs know, because some areas they will support with testing of stool samples, but also looking for the diagnosis that could be making residents unwell. If it's a residential home and there aren't any support from nurses or district nurses on that day, it's really important that we emphasise the need for like fluid charts and the care home seeking medical advice for their residents from the GP. It's also really important that care homes let district nurses know and other professional visitors, physiotherapists, advanced nurse practitioners and others coming into the home. And it's really important that that local authorities are aware of some of the high risk settings, such as care homes that you're working with, when they have an outbreak, because there might be links to more wider community transmission of norovirus in your area between schools, nurseries and care homes. Next slide, please, Raj. So this is one of the acronyms that we really like. It's called SIGHT, and it's a mnemonic to help you just remember some of the important parts to think about in a probable suspected norovirus outbreak. The residents in a care home setting or the residential setting, they might be infective and there might not be another cause of their diarrhea or vomiting symptoms when the outbreak is suspected. I is for isolate. It's really important. We do this regularly for COVID. We recommend self-isolation, but for norovirus also, it's really important to isolate residents with symptoms and also to cohorts when that's necessary in care homes. And for care homes, because they're high risk settings, please ask the care homes, as well as letting you know the local authority, to let the UK HSA know and let the GPs for the residents who are unwell be informed as well, because the GPs and primary care will support the care home in managing that outbreak also. G is for gloves and aprons. So we're all very much familiar with PPE because of COVID, but it's equally important for infectious diseases such as norovirus. Gloves and apron, really important, but also alongside other standard precautions of infection prevention control, such as hand washing. So while they are brilliant, obviously got to be done and doffed appropriately. And Emma will talk about more of this IPC measures a bit later. H, as I've alluded to before, hand washing, so important, often seen as quite a basic measure, but it really does help prevent and break some of the chains of transmission for norovirus. And T, test the stool by sending a stool sample or specimen. This is really important, and it's important that as soon as an suspected outbreak is notified for norovirus, requesting stool samples early, because at the beginning of an outbreak, it's easier for care home staff to organise to get the samples collected. So next slide, please, Raj. We do appreciate that not all areas will send stool samples, but if your area has the opportunity through your local labs for stool samples to be sent, then it will help confirm that clinical diagnosis, and other measures will be taken prior to getting those results back. Documentation is really important. So our role in health protection is to provide the necessary health protection advice. When it comes to settings such as care homes, we do not give medical advice, but it is appropriate to ask them, do they have fluid charts? Are they documenting? And have they informed their GP who looks after their care home, GP surgery, who has residents they look after, just so that for the residents they can seek medical advice if they're not well, and also they can see whether their residents' symptoms are getting worse or better. If they've not documented it, they won't be able to make this assessment and know when to seek help from the GPs. And if indeed any of the care home residents, for example, would need more support in terms of hospital care and treatment for fluid replacement or other treatments. Next slide, please, Raj. So I'm now going to hand over to my colleague Emma, who's going to take us through some of the IPC measures. Thank you.
Hi everyone, I'll do the IPC part of it. I'm going to just turn my camera off if that's okay, just so that it doesn't interfere with the presentation. Obviously, if you've got questions, pop those in the chat and we'll respond to those. So IPC part of it, chain of infection, which you've probably seen before. So we're going to refer this to noro, obviously, because that's what our presentation is about. So our infectious agent is obviously norovirus, and that's the top of our chain there. Our reservoir is where norovirus likes to hide and thrive, so where that bug likes to live. And this is part of your questioning when you are speaking to your care home or your setting or your school or your nursery, and kind of that'll be kind of your questioning and alerting them to where it kind of does like to live and thrive. So means of exit, I think that part of the chain is really self-explanatory. Really, we all know it's a diarrhea and vomiting, and as Sue said on the earlier slides, you can get that projectile vomit, really quite nasty, and quite a few episodes of diarrhea, dependent, whether it is diarrhea or vomiting or both. Route of transmission. So this is kind of can be direct or indirect. That can be direct with that person as they vomit. So obviously lots of the viral particles will come out usually on that first episode. So, you know, highly infectious. And then indirect onto our environment. So wherever the area of episode where they've been ill, where that vomit has been, where that diarrhea has been on that environment or on that equipment. Means of entry. Awful to think, but yeah, fecal oral. So basically hands to mouth and ingestion directly into the GI tract. And then susceptible host. Norovirus doesn't need anybody susceptible. It just will go to anybody, basically. It isn't choosy. So it will affect and attack anybody from a young age right through to the elderly. And that's kind of really our chain of infection, I think. And when you speak into your settings, just bear those 6 points in mind, because as soon as we can exclude and break one of those, we can stop that further transmission within that setting. Can I have the next slide, please? So as I said before, breaking that chain. And dependent on what organism, what bug that you're looking at, it's about how we break that chain and stop that transmission. As soon as we can break one of those links of those 6 chains, we can then stop any further transmission. Okay, so it's looking at things that we'll go on to in the next slides about PPE, hand hygiene, management of waste, linen. Okay, so that's about the breaking the chain and preventing any further infection. Next slide, please. So these are our standard precautions, okay, which you're probably all really familiar with because of the work that you've been doing around COVID. Okay, the ones that are highlighted in yellow are the ones that are really pertinent for norovirus. So we will go through them in each slide, each topic, kind of each key point in further detail, but it's about hand hygiene, PPE, which everybody is aware of now, it's definitely on the map, safe handling of linen, of waste, environmental decontamination, equipment decontamination, spillages and patient placement as well. Next slide, please. So hand hygiene, most basic form that you can do in order to get rid of any infection. And it's about making sure that you are, when you're chatting with that setting. I spoke to a school the other day and somebody said to me, oh yeah, we're using alcohol gel. That's not going to work with norovirus. Anything that's from the GI tract, anything that is organic matter that's on the hands are visibly dirty, alcohol gel isn't going to work. So what we need to do is be washing our hands. Ideally, you need liquid soap and paper towels to wash, good action to decontaminate and remove that organic matter off the hands and then towel dry. You need to be washing your hands when you're dealing with, when anybody has dealt with diarrhea and vomiting, obviously removal of PPE, removal of the gloves, using the toilet. Really important with norovirus before eating and drinking. And that also is obviously residents' hands as well and little ones in schools. What are their processes and practices that are in place to make sure that they are washing their hands, and what are those processes that you would be discussing with them? Okay, next slide, please. So 5 moments of hand hygiene. This was the World Health Organization campaign, which was really highlighted in kind of the press, which you've probably seen. And we've used this for many, many years. And it's kind of those 5 points, making sure before that patient contact, before an aseptic task, after bodily fluid exposure risk, and after contact with the patient surrounding, and after contact with that patient. Obviously with noro, it likes to get into that environment, so it's really important that hand hygiene is done when you've touched anything within that environment. So coming back to our hands again. Next slide, please. So PPE, so we're going obviously through our standard precautions now. So you will be very familiar, I would imagine, with all of these pieces of kit and our PPE. So face shield, obviously, we're going to masks, gloves, aprons, and obviously if you've got that risk of that splash, if you're cleaning up a spillage or within the environment, if somebody is actively vomiting, that risk of that splash into the eyes or into the face, you're going to want to be using your face protection, and obviously long hair tied up within those kind of care settings, bare below the elbow as well, obviously. Next slide, please. So donning and doffing, these are our posters that came out ahead of kind of our COVID campaigns really. And I think within settings such as care homes, making sure that if you have got an outbreak and you're chatting to those settings, making sure that just speaking with the care home manager and saying, right, when was the last time staff kind of revisited that donning and doffing processes? Do they understand what they should be doing? That's okay to revisit that. It's okay. There's a brilliant YouTube video that they can watch and go through. The area where we kind of fall down is when we doff, when we take that PPE off. And it's making sure that we do this in the correct process, that we don't contaminate ourselves, contaminate our clothing underneath. And it's that getting it right that will stop any further contamination. It's okay to put posters up in their environment. Obviously, I'm an IPC nurse, so I like everything laminated so that it can be wiped clean, and making sure that we obviously do it in the right order, refreshing it and bringing those IPC standards to the forefront of staff's mind. And that's part of your conversation that you'll be having with those settings. So it's just making sure that have the staff had their IPC training? Are there any staff that feel that they could do with a refresher, revisit those topics and bring that to the forefront? Next slide, please. So person placement. In an ideal world, we can isolate everybody. In a school, great, we send children home. So send them home, you get that bug, you get that child away from that setting. Okay, we're breaking that chain. In a care home, as Sue said before, you can't send them home, they're in their own homes. So isolation, ideal, and in a perfect world, that's what we're going to do. Obviously, we have to risk assess, and it's not always safe for somebody to be placed in their room in isolation, which you'd be really familiar with dealing with COVID and these settings. So it's about, okay, so the home needs to do that risk assessment. Is it safe? Sometimes it's not safe, and we've got to then manage it in different ways. So it's about cohorting. Can we move these people into an area together that they can be monitored, set staff, no floating of staff, making people safe? If they can be isolated, great. Just making sure that we've got call buttons, these, really simple things, but it's worth revisiting that and talking through with the setting. Regular checks, really important that they're able to hydrate. As Amanda said earlier, I always ask, what have you got in form of documentation? So have we got a fluid balance in place? Have we got documentation for a stool chart? I quite like the Bristol stool chart. And really important as well, when you're assessing kind of the situation, you're getting symptom onset and symptoms of those residents. What is their normal stool pattern? Things like laxatives. In my time as IPC, we've had like laxative outbreaks, making sure that they are revisiting what medication is being given, and also obviously that clinical kind of their escalation processes that are in place, making sure that if they are isolated, they've got their own kind of designated commode. Okay, we don't want that being moved through homes. Kind of common sense things to us, but obviously it's worth revisiting that. And when you're speaking to that care home manager, making sure that you are bringing those things into that conversation. Next slide, please. So food preparation. I always tend to ask, as Sue said earlier on, is our cook ill? Anybody of the kitchen staff that are feeling unwell, it is your key thing. Has the cook been sick in the kitchen? Have we got a load of sandwiches that have been prepared for that day? Obviously, you're not going to want to be handing out those sandwiches. Making sure that surfaces are clean in the kitchen, that we have got good hand hygiene practices. And it seems really simple, hand hygiene, but it's one of the most effective things that you can do, is making sure that you're washing your hands properly. Ensure that crockery and utensils are clean. I quite like the clean and covered kind of thought process. Before COVID, we used to have, I'd go into a care home and there'd be bowls of fruit in the kind of restaurant area. We'd have you sometimes have trays with kind of knives, forks, spoons all out. So you don't want any of that. And I think with the process of COVID journey, a lot of that has been moved now, and things are covered and they are put away, locked away. We want to make sure that we're protecting anything around that food kind of prep. really important as well with norovirus, what's the hand hygiene practices that are going on with our residents in that setting, and also as well with schools, making sure that our little ones washing their hands, you know, what's kind of the setup there, what are their processes in place so that we don't get any further transmission. And then removing the lovely kind of artificial flowers and tablecloths, making it the environment not sparse and horrible, because it is a home for some people in care homes, but obviously we need to make sure that we've got wipeable surfaces. Next slide, please. So this is kind of decontamination, some lovely pictures on there. So it's about thinking about what cleaning is in place, making sure that they are using the appropriate cleaning products and that they are following kind of their cosh data and their data sheets. Looking at the equipment that's used as well, and we'll go in the next slide, we'll go into this in further detail. Are they cleaning the actual cleaning equipment using the correct coding and the colour coding system from the cleaning standard guidelines? Touch points that enhance cleaning, that hand there on the door handle, which is all part of, which you'll be really used to doing with your COVID stuff, how equipment and that environment is being cleaned, and the environment around that resident or the environment where that episode has happened in the school, where that vomiting has happened or that diarrhea. Next slide, please. So cleaning. Stage 1, obviously, good old hot soapy water, making sure that we're cleaning with soap and water, that vomit, getting that spill up and cleaning that. Sorry, my PC's making noises. Hot soapy water, clean that. We're then going to use our disinfectant as our next stage. So I quite like chlorine. I think, you know, it's been around forever, and it's that chlorine dilution of 1,000 parts per million for those bodily fluids. Obviously, that is different with blood. You go 10,000 parts per million. Making sure, as I'd said before, our cosh guidelines, any setting should have data sheets, their cosh data sheets within their setting, and making sure there are very fancy cleaning products on the market. A lot of companies have come on now with new cleaning products, in making sure they're using the appropriate cleaning product for what they're cleaning, what that bug is that they're cleaning up. So it's worth just to chat through that and prompting their processes that are in place. Stage 3 is then drying thoroughly. Okay, so making sure that we are drying that area, and then obviously the increase on that. So do you want to come in any more on this part about increasing cleaning?
Yeah, I was just, I have to apologise for this slide. It's because we had a fancy programme that said, do you want to arrange your slide this way? And I said, oh yeah, let's try it, and it won't go back. So I don't think it's very clear. So that's my fault really. But yeah, so what we wanted to say there was, and I appreciate, and I've been reading some of the questions in the chat as well, and I'm hoping, and it's difficult to pitch this at the right level because we weren't sure exactly who was going to be coming on and what the speciality was. And I think there's been a question of, you know, are there IPC nurses in local authorities? Well, in the local authority that I came from, yes, there were IPC nurses. If you're a local authority that hasn't got those IPC teams that can do this advice and check that your care home schools have got this in place, then I think as far as the stakeholders are concerned, you need to find out who is in charge of their IPC. But just to go through this slide a little bit, it's making sure that they have got in place the right cleaning. Again, it goes back to policies and procedures. They're cleaning twice daily minimum during an outbreak. There's increased cleaning of touch points in high traffic areas and in between. There's a deep clean after each uncontrolled episode and at the end of the outbreak. So when I say uncontrolled episode, it means that somebody suddenly vomits in the middle of a room, then all potentially that environment is contaminated. As we said earlier, it can reach 3 meters projectile vomit. So who's going to clean that up? What you're going to clean it with? And are the processes in place to ensure that that deep clean has happened? your basic standards of cleaning are changing mops and water between affected areas, use single-use cloths which are all colour-coded, the correct PPE to protect the people who are cleaning. And when they're cleaning, are they cleaning correctly? Are they moving from the clean to the dirty area? And cleaners' trolleys should always be cleaned after each use. If your cleaner's trolley's not clean, then your equipment's not clean. Therefore, you're taking contamination all around the home. So the big questions are, who are the cleaning team? Have they got enough cleaning hours? Have they been trained? Is there an adequate handover system for cleaning? Like, I've managed to do room 1, but I never got round to doing room 2 at handover point today. That one needs cleaning. Are they labelling clean and dirty items, as far as equipment's concerned? So how do you know what equipment has been cleaned and what hasn't? And are council teams then able to support that process? And when I say support it, when I worked for our local authority, we had a local authority cleaning team who, if a school was in an outbreak situation and they hadn't got adequate cleaners, our council cleaning team would go in and they would do a deep clean for them. So are there things like that in place that you can call on? And if you haven't got that at the moment, it's finding out where you could get it from, or indeed where the organisation that you're dealing with has got a contingency plan for that to happen. Because in an outbreak situation, you will need more cleaning, inevitably. Yeah, sorry, Emma. Do you want to carry on with slide 26 now?
Yeah, of course. I knew you wanted to come in on that one. That's why I asked you to come in.
Yeah, that's fine.
So next slide.
Yeah, sorry. Right, next slide.
So safe handling and linen. So back to our standard precautions, really. I love that picture up there of the bath. Hopefully you will never see that if you do go into a care home. So that's that open sluicing. So they're soaking, basically closing the bath. And you can just see the lovely bubble bath and the shampoo. And hopefully there's not toothpaste and toothbrushes that are sitting in the sink next to that bath. So care homes definitely should have that red bag there. That's a red alginate bag, and they go directly into the washing machine. And so it's about not open sluicing, so it's making sure that asking the care settings, particularly more really care homes really, for this slide, about what their processes are. Okay, so infected linen should go at the highest temperature that fabric can take. Okay, some settings will have the industrial washing machines that does have the sluicing setting that's actually on there, which is like the pre-wash setting, and obviously the red alginate bag is used. And the key thing for me is when I speak to a setting is about, okay, so what's your process for removing that linen from that infected kind of residence room? How are you moving that to your laundry area? And making sure that whatever they're using to move that is obviously then cleaned, and then it's not going to other people that haven't got that infection. So kind of like your common sense kind of questions there, and how they're moving that and their processes that are in place. And then obviously when you just questions about really the laundry, is it, we haven't got kind of that infected linen waiting for the, a cycle to finish, that it's moved and it's cleaned promptly really, and that any clean laundry is stored in a designated area, that the clean laundry is not sitting in open kind of pretty baskets there where you can get that risk of that environmental contamination. So that's really with laundry really. Next slide, please. And then lovely picture there. So safe disposal away. So obviously another one of our standard precautions. So making sure that whichever setting you're talking to, that they're following their waste policies and their waste stream guidelines really. Bins should ideally be foot operated and lid in. IPC nurses love foot operated lidded bins, and making sure that we've got prompt removal of that waste. You are going to get more waste in an outbreak, so it's just asking that not all care settings will have a clinical waste collection service. I believe it's more than 50% they have to have in order to qualify for that clinical waste collection. So how are they coping with their waste? They can get additional waste collections in an outbreak scenario, so it's about making sure that they've got that prompt removal of that waste. We've not got overflowing bins, and just following kind of the waste guidelines. Okay, next slide please. And then spillage. So key thing, obviously, making sure that they've got the appropriate PPE on and a risk assessment. If somebody has had that episode of vomit in that lounge or in that school dining room, we want to clear that area. We don't want any kids running around carrying on eating lunch. We want to make sure that they are, if they're an ongoing outbreak and they're chatting to you, it's really important, if somebody is unwell, that people are cleared from that area. We're going to bring in chemicals in there and we're going to be cleaning that up, and you don't want care home residents or little ones around there. So mopping up, obviously, with the spillage, you want to clear up with paper towels, disposing of that. Clean the air, as we said before, with the decontamination slide about soap and water, and then back to good old chlorine, so 1,000 parts per million, and that will deactivate the virus. And then with blood, you do use 10,000. It's a stronger composition of the chlorine on that. Never put chlorine directly onto urine spillage, and then making sure that removal, that doffing of that PPE is done in that correct order, and then obviously washing your hands are really important. Can't stress that enough. And then, as I said before, making sure that they have got the correct chemicals in place and their data sheets that are in place for the appropriate cleaning equipment for the appropriate kind of bug. Next slide, please. So this is the last one for me, because I'm sure you're all sick of hearing my voice. So this is just a summary really of the outbreak management really. So for care homes, really, it's about isolating that resident. They should all, I would hope that they would do that. So somebody that's symptomatic, get them isolated. Make sure that we've got hydration in there. They will get dehydrated really, really quickly if they're, a severe attack and they've got lots of vomiting and diarrhea. Little ones, I'll stick with care home, sorry. So rehydration, so making sure they've got a fluid balancing chart in place, making sure that we've got a Bristol stool chart, making sure that they're aware how many episodes of diarrhea, how many episodes of vomiting that person is having. Sample testing if possible, definitely. And I think the key thing for me is that escalation process is in place for that setting. I think this came really on the map with COVID, making sure that, not all residents were symptomatic with those classic 4 symptoms of COVID, but you need to have that escalation process. If somebody's becoming unwell, how are we going to escalate that? That care manager needs to make sure that the clinician, the GP, is involved in that.
Emma, we have a question from Alicia. Alicia, do you want to come in?
Yeah, thank you. Yeah, just it was just around steam cleaning really, and thoughts around that. Obviously, we've talked a bit about cleaning really, but for fabrics, carpets, things like that really.
So really, for anything fabrics, remove what you can and launder those. Obviously, you can't always launder that. So it's about removing any spill organic matter from that fabric. And I mean, I remember being in care homes. I don't think there's a kind of recommended steam cleaner that's there, is there really, when I've gone in and done audit and standards. So it's about obviously a good steam cleaner that you've got, removing as much of that matter that you possibly can. And when you do the steam cleaning, obviously making sure that you're clearing that area, well ventilated, and you can get kind of the units that pull back the water, so less aerosol on that. So ask them about what they're using, really what they're using, what kit they've got there, and making sure that it is an appropriate kit really. Would you want to
ideally, sorry, I was just going to say, Emma, ideally you would want a professional steam cleaner. Yeah, so it does a good job, because the risk with that is if you're steam cleaning and you're hitting your curtains and it's splashing back and aerosoling everywhere, that's what you've got to be careful of. So the person doing the steam cleaning needs to wear full PPE. You need to clear the area and have a professional cleaner, and that's the general guidance on that. But it's a good question to ask, because I've asked that myself a number of times. I think if you can avoid steam cleaning, then do it. But if that piece of linen, cloth or equipment has got to be steam cleaned, then that's the safest way to do it.
Yeah.
Sorry, can I just come back on that? I mean, we had a norovirus outbreak. It wasn't in a care home setting, it was in a sort of hotel setting really. And at that time we were advised that only steam cleaning would sufficiently remove it. That just cleaning alone would not be sufficient on a carpet where people were walking through. So I think it's just us all being clear on where we are with that. I understand the issue around, the spray and all the rest of it. But, are we saying no to steam cleaners now because of the risk of spreading it, or are we saying that, that's the case because they were quite insistent last time that, the area was steam cleaned and that would be the only solution to it, really.
Yeah, well, things like carpets, you can't take up and launder them, can you?
Yeah.
Obviously.
Fortunately.
So carpets, yes, would need to be steam cleaned, particularly if somebody's vomited or had, unexpected diarrhea there. There's no other way of removing that virus. The only other thing that you can do is vacate the area, clean it with soap and water, and then chlorine if the carpet or material will withstand it, and then just not go back into that
Just leave
area
it,
for
Yeah.
like 14 days or so, because then we know the virus will die if it's not on a host, as we said earlier on. But I mean, the best advice, if you can get in there early, and that's what's really useful if people do report outbreaks to you, is to remove anything that can't be cleaned with a chlorine base. So things like, and I know you're talking about the bigger items, perhaps like carpets and maybe the heavy curtains, but it goes back to like when you're involved in the care home process to begin with, it's everything really needs to be wipeable or removable to launder. And I know you can't say that in a hotel situation because you don't have that input, but things like removing tablecloths or dry flower arrangements or anything that can collect that virus, then just remove it. Or anything that you think might need steam cleaning, if I can remove it early on, that's the best plan. But yes, if you do have to steam clean, correct PPE and a professional steam cleaner is the advice.
Thank you, Alicia, for that question, because this is
Thanks
often
very
a
much.
debate that we have amongst ourselves and with other sectors. And I think we've had norovirus outbreaks where curtains and a GP practice have been a real challenge, because we'd obviously asked them to remove any curtains where they've been exposed to vomiting patients, and they, when we've audited, have been found to hold the norovirus. So I think it's a really valid question and really important. But back to our basics.
Is that helped?
Yeah, that's great. Thanks.
It's a difficult one, isn't it?
Yeah, that's fine. It was just for clarification because it wasn't really mentioned steam cleaning on
Yeah,
the
sorry.
regime,
Yeah.
really. So
yeah, unfortunately you can't put a load of chlorine down on a nice carpet, especially not in a hotel.
No.
So yeah, unfortunately. So it's about removing the items that can be removed to launder. Obviously, as Sue said, you can't remove a carpet. So and minimising what does need to be steam cleaned, really. Hotel, I would imagine they'd be able to take curtains down and things like that, and any soft furnishings that can be removed and be laundered. So you're removing the viral particles off that. And then obviously it's just going to be kind of your furniture and your carpets that are going to be your key things, really, the ones that you can't lift up and stick in the washing machine. So yeah.
Thanks very much.
Is that okay? Sorry. Yeah, so
Great.
clinical opinion, really, and then coming back to our IPC standards, advice to close the home, and that would be to admissions, transfers and discharges, and then obviously exclusion of staff until 48 hours after last symptom. Sue, do you want to come in for the schools part?
Yeah, I'll just do the schools
Yeah,
one quite
sure.
quickly. So exclude symptomatic pupils and staff until 48 hours after the last symptom. Make sure that they are washing their hands with liquid soap and water and drying them on paper towels. During COVID, people have become over dependent, I think, on gel, and gel's not effective against norovirus, so keep bearing that in mind. Decontaminate, that's the fancy word for cleaning, but make sure it's done properly. Communicate, as we've said earlier, to all your stakeholders, and report it and record it. So that you've got a list of like who's symptomatic and when they can come back into schools. This is the advice I think that local authorities would be giving to schools. We're not expecting local authorities to do all this reporting and recording of every norovirus situation. There could be quite a number. I know we've done like an in-depth one on COVID, and we've kept all those records, while some local authorities have, as have UK HSA. But norovirus, it is a self-limiting disease. It will come and go, and while we want to stop it transmitting as much as we can, then we've got to also accept that we can't have control over everything. We have to depend on the schools having their own policies and procedures to be able to deal with that. Okay, next slide I think is just a resource one. So I'm not sure whether with the schools any one of you has had any experience of eBug. This was rolled out a couple of years ago by the old PHE then, which are UK HSA now. It's a resource that is particularly for schools, but it runs alongside the national curriculum and it tells children all about bugs. I've learned a lot from this myself. There are little experiments that they can do in there as well that helps them to understand how bugs live, transmit, and I've put in the references at the bottom a link to that. So if you can try and encourage schools, so it's from nursery right the way through, right until A level, to use that eBug resource. My son's teaches physics in a secondary school and he loves it, and it does run alongside the national curriculum. So I just think it's just a really good resource worth knowing about. Next slide, please. Now, I'm aware that now that we've come to the scenarios bit, and I'm also aware that there's a lot of questions, maybe some unanswered, some we've tried to answer as we've gone along. But I want to just open up, and I hope Amanda and Emma all agree with this, the floor now. For us, we've talked long enough. Do you want to tell us what you need to know? Is there anything that we haven't covered that you want us to? We've given you a lot of background on infection control because these conversations with the care homes and with the schools are all to help them, to support them, to put in place the things that would stop an outbreak spreading. Okay, so these are the bread and butter ones. And at the beginning, I said there might be some more experienced people on here. I'm not sure whether we're pitching it at the right level. I apologise if we're not, but I think we just need to ask you to talk to us now and tell us what more you need to know. Is there anything that we haven't covered? What would you like covering? Because it's not the be all and end all. We can have more sessions if you want to. So, Amanda, do you agree with that? And
Yeah.
Yes,
shall we just open the floor up now?
We've had some
Yeah.
really excellent questions and some comments, and we appreciate each local authority works differently, has different commissioning roles and responsibilities, which will then influence what they do in relation to sectors such as care homes.
Yeah. Is there anything that anybody would like to? Does anybody brave person want to talk to us? And put your cameras on if you do. We want to put our cameras on and try not losing connection because I hate talking to blank screens. So I'm going to try and put mine on. And if we do all lose connection, then
System will probably blow, yeah.
off. But then do you all want to just pop your cameras on for a minute and then let's just see. I'm used to doing sort of workshops prior to COVID, where we actually went in and we taught care homes and did workshops, and we taught them MRSA, decolonisation, all sorts of things really. And it's much better than talking to blank screens because I don't think
I've got a query.
Yes, carry on.
So
Hi.
should we work on the, hiya, I'm Kim, I work in Staffordshire. Should we work on the assumption, given that the testing results might not come back for 2 to 5 days, where we've got people with what we'd call pretty typical norovirus symptoms, should we work on the assumption that it is norovirus in the meantime?
Yeah, there is, if I could answer that one, if you don't mind. Yeah. I mean, the labs actually, if they get a sample into the lab, they can turn that round in a number of hours, between 2 and 6 hours, I think it is, depending on the system that they use. But obviously there's different labs everywhere and different means of communication to that result as well. But in the absence of a result, then there have been what they call the Kaplan criteria that you can apply. And in general, that's half the cases have got vomiting as well as diarrhea. Diarrhea is mild without mucus. There's no blood in the stools. And 20% have perhaps malaise and a low grade fever. so there is that Kaplan criteria, but I know that that's been challenged as well, and it's questionable. So in answer to what you're saying, Kim, I think if you've got a number of people who've got diarrhea and vomiting, and they are showing those signs and symptoms, then keep them isolated until you get the results. Assume it's norovirus until it's proved otherwise, because what you don't want to do is say, oh, it's probably not, let them out into the communal areas, and then it spreads, particularly in a care home.
Thank you. And just a second one in terms of the timescales. You talked about closing a home that has multiple cases. We work with private hospitals and hospices. I'm assuming the same thing is what you would recommend, but it's the time period of how long the outbreak status stays in COVID. We've got an outbreak status that stays usually for a minimum of 14 and sometimes 28 days after the last case. But is there a set time of when that stays for norovirus cases?
Yes, so what we normally say is 48 hours after the last symptomatic person. If you've got 20 people in an outbreak situation and it's the outbreaks lasted over, I don't know, 15, 20 days, hopefully not, but if it did, so the last person who had any symptoms, so whether that's vomiting and or diarrhea, you literally count 48 hours and then deep clean and then reopen. That would be the advice.
Thank you.
Okay. Sorry, someone's got the hand up there.
Mike, would you like to?
Mike Calverley from Staffs County Council is I thought that was pitched perfectly for those more experienced and less. I've certainly picked up a few things I didn't know, facts and figures. I love them, so that's good. It was my question was in terms of say in a care home and it's looking, you've got old and vulnerable people there. How practical is it actually to get stool samples, and is it actually really necessary when it's pretty obvious it's a norovirus outbreak?
Yeah. That is a really good question, and believe you me, we've lived that on the front line as well. And I've worked in a hospice, as Kim was talking about, for a couple of years as well as a palliative nurse. So yeah, I mean, the elderly, as we know, are very often in incontinence wear. And if you've got watery diarrhea, it sinks into the pad. That's the practicalities. And sorry for those of you who are not perhaps used to dealing with diarrhea. But that's really, really difficult to get that sample. All I would say is the labs have told me, and I've done this myself before, that you don't need much on your in your pot to actually get norovirus tested. They've even told me that you can get a little bit on the end of a swab, break the swab off a little bit like we do for COVID, pop it in a pot, and I can test norovirus off that. What they can't do though is culture and sensitivity sampling or C. diff, and they usually run those tests off at the same time just to rule out whether it is might be a C. diff infection or culture and sensitivity like Campylobacter, etc. But back to the practicalities, if you are able to even get a small amount of diarrhea into that pot, then send it. It's useful to get at least one confirmed sample, then you don't need to send others really, because if you know you've got norovirus in the home, you can pretty much say that's what's doing it. All I would say is if someone has got prolonged diarrhea over and beyond the outbreak, then you need to get a clinical oversight of that just to see if there's any other reasons for it. And obviously consider things like, are people on laxatives? Have they had an enema the night before, or have they been constipated and it's overflow? These are the clinical oversights that you need with the care home, and I'm not expecting all local authorities to have an understanding of that unless you've got a clinical knowledge. But going back to the organisation, it's checking that people within that organisation have got people who, and then they've got the understanding that they need to get a GP review or a rapid response review as well, so that we're not ignoring things.
Thanks for that.
That's okay.
Thank you, Mike. That was a really important question, because not all areas send stool samples to the lab for norovirus, and that is actually okay as long as that outbreak is being managed. However, we all know from experience, those of us that have worked in these settings, it's better to get that sample off earlier when they first become symptomatic with diarrhea, manage the outbreak or suspected outbreak, and then once you've got that result, that can just support if the outbreak is prolonged, also helping keep in mind that something else may also be happening at the same time. So really great question, and all questions are welcome.
That makes perfect sense.
Thank you. Right. Has anybody, Stephen Whellan's got his hand up? Stephen? Hi. Well, I think you might be on mute.
Hi, thank
Stephen.
you.
Hello,
Can you
yeah.
hear me now?
Yes, got you. Yeah, we can
Hi,
hear you.
Stephen Whelan from Birmingham City Council. I've had a bit of experience in the past with outbreaks, which we think have the spread has been caused by inadequate clearing up of the vomiting. I'm just wondering what your thoughts are on this, because what we tried to instigate was spill kits, and for settings to have like spill kits, so you've got something which will absorb it, and then making sure that they're wearing masks as they're clearing it up. Because I mean, I might be wrong on this. That's why I'd like some guidance from you professionals, that if this becomes airborne, although this is transmitted through ingestion, can that be absorbed or taken in into the mouth as particles and then ingested that way? So we instigated these spill kits and then wearing the masks whilst they're clearing up the vomit. I'm just wondering if that's something you've heard of before, whether you would advocate that.
Yeah, I mean, spill kits should be available in all organisations in case you get a spill, not only of norovirus, but in case you get a blood spillage as well. And just to bear in mind that the blood spillage concentration of chlorine is much higher. It's 10,000 parts per million, whereas just for normal other fluids, really, it's 1,000 parts per million. What you've got to be quite careful of is not putting, if you've got a urine spillage, don't put chlorine directly onto that urine spillage. So spill kits sometimes advocate sprinkling the granules, which is good and great and should happen on blood spillage, but not really on other bodily fluids, because it can interact and throw off chemicals that can put you in A&E for a day, which is a day of work, but not a good way to do it. So what we advocate first of all, and plus spill kits are quite expensive if then they come with a single use. What we advocate is, when we went back, I'm not sure if you can find, which slide was it on spills? Let's have a look. Oh gosh, where am I? Anyway, I'll tell you what it is, because I can't find the slide right now at the minute and talk at the same time. So it's covered if you've had someone vomit in a communal area, okay, put PPE on. So you've got your face masks, your goggles, gloves and apron if that person's going to clear it up. Paper towels, first of all, to absorb the majority of the spill, okay, as much as you can, and into a waste bag that you've taken with you. If you've got a clinical waste stream, or if they've got a clinical waste stream, that's ideal. If not, a general waste bag. And then clean the area with detergent and hot water. So that's a soap-based detergent and hot water, followed by chlorine mixed at 1,000 parts per million, which can be, you can buy that sort of over the counter. Milton is a common one, and especially used in schools, or any of the bleaches, mixed at the right concentration to get that 1,000 parts per million. Make sure that the contact time is enough, and if you can allow the area to dry rather than wipe it dry, that's ideal, because it's had enough contact time. But if it's in a slippy area like a floor, just cordon it off, make sure it's had the correct contact time, and make sure it's dry before anybody walks on it again. So yes, spill kits can be used. I would advise you read them carefully about how to apply them to different body fluids other than blood, because they're usually designed for blood. But in general, it's get the majority up with paper towels, dispose of that, soap and water, followed by a chlorine mix, and then leave to dry, or dry it if it's in a slippy area. That's the ideal. And you are right, cleaning is vital. And that's why we did spend quite a bit of time on the infection control bit, because, you know, if areas are left where there's traces of vomit or diarrhea, they can live in that area for up to 14 days with norovirus. The next person to come and sit in that area or eat in that area potentially is infected then. As we said, it only takes 18 vomit particles, or not vomit particles, virus particles, to infect somebody, which is just so few. You can't even see them on a pinhead.
That's great.
Yeah.
Thank you.
Okay.
Thank you, Stephen, because cleaning is so very, very important and should be done, as we all know, as soon as possible, but it's not always as easy for the settings to do that if they've not got a cleaner coming in till the next morning. Ideally, what should be done on the same time it's happened, the episode, vomiting or diarrhea, and it's really important. So thank you. Does anybody else have any questions? Or I think at the beginning, if there's any situations that you're working on without discussing the name of the place that you might want some just general advice on, or obviously we can discuss outside of this meeting, but are there any other questions that anyone has? Doesn't matter if they're small, we're quite happy to answer them. There's some really great comments in the chat about locally in our local authorities, working obviously with the UKHSA, how do we coordinate who's going to lead on an outbreak? So we're all working on COVID across the different settings, and we've worked together to decide who's taking the lead for COVID in different settings. For norovirus, obviously last year it was very different winter, whereas this winter and throughout the spring, we're seeing more norovirus cases. So I think each local authority area has a team at the UKHSA who they meet with regularly.
These arrived.
We're happy to support each local authority area with their liaison health protection practitioners and consultants to meet regularly and to make sure that we are supporting around the norovirus pathways. But what we had a really great suggestion from Sue in terms of having some networks set up for our local authorities, where the UKHSA can coordinate and work with local authorities to have networks with your neighbouring local authorities in terms of supporting that knowledge and intelligence around infection prevention control, and sharing best practice as well. We're quite happy, Sue and Emma.
Yeah, I was
and
wondering.
Raj.
Yeah, I felt when I worked in the local authority, I would have loved to have, and we did have some neighbouring authorities that we spoke to, but I would have loved almost a forum to say, what have you done about this? What have you done about that? You know, how have you tackled this?
Yeah.
And I just thought, if you were all happy to do that and wanted to do that, maybe if you could put a generic email into the chat, we'll try and get something together where you can, you know, well, if we just provide that forum setting where you can ask each other questions, or we could even have like a fax page or something like that. It would be the beginnings, I guess. But if you feel that would be beneficial, pop your generic email address in the chat, and we'll try to coordinate that if you think that's a good idea. Yeah. So, go on. Sorry, Em.
Yeah, I just want to check, have we answered everything?
Yeah, I was looking through as well.
Have we answered
if we haven't answered, if you've still got a question outstanding, could you say it out loud, because there's quite a few and I can't read them. Could anybody put the hand up if we haven't answered your question?
So yeah.
I think we might have covered them between us. Yeah.
I think that it was just to be absolutely clear about who leads on outbreaks for the different types of settings, but I'm guessing that there isn't a single answer to that. I think sometimes it's going to be UCSA, sometimes it's going to be the local authority, and sometimes it's going to be the commissioning authority. So I'm not entirely sure that there's a simple answer.
I think you're right. I don't think there's any hard and fast rules being made about who does this. What we're finding though is, and again, I speak from local authority perspective because I worked there for 3 years prior to COVID and during COVID, that sometimes it's much better to deal with the local things yourselves, because you've got an idea of the geography, you know where where people are. I mean, one of the things that we used to do was if we had an outbreak in the school, we would inform the local care homes, because inevitably, if there's a school outbreak, there's either a children who's got a granny or granddad in the home, or a mum or dad who works as a carer in that home. So we'd inform them that, not breaching any sort of GDPR confidentiality, but would ring them up and actively say there's an outbreak in your area, batten down type of thing, and be extra careful that people are washing their hands as they enter the home, and any visitors that you've got, check that they haven't got symptoms, because if they have got symptoms, they bring it into your home. You know, the school's norovirus outbreak will have come and gone, and your care home will still have it, because you've got vulnerable people there, and it really affects them, and they become dehydrated and end up in hospital, and then it moves to the hospital then. So, you know, often schools are an informant of what's going to happen. Your care home's going to have an outbreak potentially. They're going to take it into hospital if there are poorly residents there. Your hospital's then going to have an outbreak, and then that's that vicious circle that you've got the potential to break if you know these things locally. So I felt it was really good to have a hold of what was happening locally. And so I think, and I don't know, you know, what the ask in your local authority areas are, but if you have any opportunity to input into that, that would be my suggestion, really.
Thank you.
And obviously UKHSA will always be there to support that in any case. So if you're struggling, I think the general guidance, I'm sorry, I'm talking a lot, but the general guidance, I guess, is if the school can't control it, we'll talk schools as an example, the school can't control it, then they'll contact the local authority. If the local authority support can't help in any way, i.e. practically like sending in extra cleaners from your council, or supporting by, you know, saying, have you got this infection control in place? I mean, we visited schools in our local just because they've got outbreaks, and you wouldn't imagine the amount of problems we found there, because everybody can tell you it's okay on the phone, but you go and visit and you see, you know, underneath the hand gelling stations are really dirty. So people's hands are more dirty when they come from out of the hand, you know, under the hand stations than if they'd gone in them before. The toys, I've seen black dolls. No, sorry, that's not meant to be black dolls. That's meant to be dirty black.
Oh.
They are filthy.
Dirty.
And these are toys that children pass between them and play all the time. So, you know, schools could say, yeah, we've got regular cleaning, but have you thought of everything? You know, then there's kiddies like delving in the sand pit, and you think, oh my goodness, you know, sand, you know, it'll carry all the bugs in the world, won't it? So it's sometimes actually going out there and having a look, if you've got the resource to do that, tells 1,000 stories. You know, a picture tells 1,000 words. Is that what they say? So yeah. So for me, locally would be good. UKHSA to support, but obviously if you haven't got that capacity, then, you know, we can do those telephone conversations as well.
Thank you.
That's okay.
I hope that helps. Has anyone else got any questions? So we will be in contact with Miriam. So it's a network really, so that if your area is thinking about how you might approach supporting different sectors with their outbreak plans, we've obviously got norovirus toolkits appropriate for care homes at the UKHSA, which we can share with you and which we have previously shared with care homes. But sometimes it's good to have a network with other local authorities, and there might be something that you think is quite a good example of best practice which you might want to adapt. At the UKHSA also, we're happy to run more training sessions for your local authorities if you've got a lot of new staff who may not have worked with care homes before, either from a clinical or not commissioning background. We're happy to support working on pathways with you on a more smaller group setting. We have got some scenarios which we will send to you in the pack, but I know that Michelle at the beginning said they were managing a few norovirus outbreaks. Are there any situations or scenarios you might want a bit of advice on, or would you like us to run through a quick care home scenario in the last 5 minutes?
Silence.
No, hello, it's Michelle here. I think
Hi,
Hello.
Michelle.
thank you. I think I did say we would be managing norovirus settings and other public health areas. We're not currently dealing with any, as far as I'm aware, in any of the care homes. It's
Which is good.
COVID at the moment, but I'm sure it's coming.
What we can do, Raj, please can you move the slides along and I can just show the scenario around. So actually that's that one. So can you go back to the one before, please? What we'll do, we'll just in the last 5 minutes just talk through a scenario. So Michelle, here's one for you, but it's open to everybody on the call.
Thank you.
We're on the COVID response cell for the local authority. We get a call from a care home manager who's really concerned because for the last day they've been having residents and staff have been coughing and vomiting, and she's really concerned because quite a few of her staff are not well and not coming into work, and also a lot of her residents are becoming quite unwell with coughing and vomiting. So this is open up to the floor to everybody. What would you want to know more? What do you want to know next from this manager? And it's the things that we deal with all the time on the COVID response cell in a local authority setting. So happy for people just to paste anything in the chat or just to call out what might you want to know from this care home manager. I may ask Emma or Sue to start us off. So Michelle, do you want to come in?
When did it start? Dates of symptoms? Has anyone been tested?
So it started yesterday, and the testing, they have been tested for COVID. They did all the COVID PCR tests for the home for staff and residents, and the results have all come back as negative. And the staff lateral flow tests today are also negative.
Contacts? Is there anybody else with this?
So they've had a lot of agency staff working at their care home. They work between care homes and also different settings.
Okay, that's an issue. I would be looking at the agency staff, definitely. What are the protocols in place for the setting with regards to cleaning, PPE?
They've got enough PPE in stock and care home staff are using it. The manager's is going to check that they are using it as per the guidance.
Are the residents being isolated? Are they being cohorted with certain staff who are cohorted into certain areas? I
will let you know that this is an elderly dementia care home. So they have a lot of residents with dementia who the care home manager tells you tend to wander. So I'm just going to pause there. Raj, please can you move us along to the next slide? And Michelle, thank you for asking the questions, because I know all our local authorities will get sometimes calls around query COVID, but when you ask a bit more, the care home manager, she tells you that actually 18 people at the care home have symptoms of diarrhea and vomiting, 3 of the staff and 15 of the residents. And you've obviously taken a really detailed history about the food sources, to where the food is provided from, who prepares it. But something that you find out about the food is that there aren't any obvious food sources. There have been some stool samples requested and sent, and they are now starting to do the deep cleans as per the guidance. They've closed the visitors, and they're advising obviously that all staff and residents good hand hygiene, hand washing with soap and water is in place, and not using the alcohol gel to clean. The results from one of the stool samples come back, it's confirmed as norovirus. So this was just a scenario just to raise that initially you may have lots of residents with like flu-like symptoms, coughing, bit of COVID symptoms, might have a low-grade fever. But when you ask for a bit more detail, some of the residents and staff have been vomiting. So it's not actually a cough related to respiratory infection. It's more the coughing because they are vomiting persistently. So it's just more, as UKHSA, we're here to support local authorities, and if there's a situation or an outbreak which doesn't quite fit with COVID, or you're concerned something else is going on in that care home setting, then please by all means do call us and we will work with you. And also if you're concerned about a point source or a food source, and we need to obviously work with our environmental health colleagues to look for any other diagnosis for the diarrhea and vomiting symptoms, please do call us. But just going to bring in Emma and Sue if there's anything else that you'd like to share about care home settings before we close, and just have an opportunity for any final questions.
Just from me, thanks Michelle for coming in on there. Yeah, I think there's a few things in the chat. Yeah, Miriam has said about what cleaning would be undertaken if they're isolated. Yeah, really good key points. Closed communal areas, definitely. If we've had an episode of vomit in those, definitely. Numbers, yeah. So we're looking at what numbers are involved, and it's about when you do have those chats with whoever is kind of the point of contact is finding out that information, locations, episode and the location of those episodes and what cleaning has been undertaken. Like we've said, obviously making sure that it is cleaned up, that episode of vomit or diarrhea, and to reduce that environmental contamination is really key. And then Miriam, I've just seen the last kind of message on there about escalating. Definitely, if you feel you do need the support, definitely that's, for my opinion, is what our role is there, is to support yourselves, and obviously escalate to us and we can assist and support always. So get anything that you want to add there?
Make sure your residents wash their hands.
Yes. Yes,
Because that is
basics.
vital. Yeah, it's basics. Yeah. Okay. And thank you all for listening.
And thank you.
Thank you. Does anybody have any final questions? Thank you, Stephen and Miriam, for also those comments as well. So what we will do now, Emma, Sue and Raj, I don't know if you just want to come on for a moment. I'd just like to thank my colleagues, Sue Hughes, Emma Woodcock and Raj Atwell for working together with us to get this presentation prepared and shared. Raj will send the recording and the slides. We're also quite happy to support any further bespoke training sessions that you'd like with your local authority as capacity allows across both your LA and the UKHSA. We'll also share some resources to share with your schools and your care home sector around IPC, and we'll make sure that when we meet with your local authorities and your UKHSA contacts for your area, that we do support any pathways that need to be developed for, for example, care homes, and any training that care homes may need, we can signpost locally how best to support. But thank you all for your time today, your questions, they've all been excellent, and we will be